to end the season. I am really looking forward to this. My name is Lucia Scholwer, and I'm the chairman of the Sundays at 2 committee. And before we get any farther, to introduce the people who bring this wonderful program to you. Two of our members are not here today, Ernie Monsheen and Sheila Stepko, but Sheila's watching, I think, on Facebook Live, so hi Sheila, we missed you. But we have Sandy Toomey and Bud Ward, who are over. Sandy's in the back, Bud's over here on this side, and Pat, Tracy's right here. She gave you her, surveys, thank you. And Alice Cooper is our library director. She's probably downstairs.
She just left.
So she's ex officio member of our committee. And we couldn't do any of this without Shelley Robertson, who is our technical guru. She makes all the magic happen. So we're grateful to that. So as Pat gave you the evaluation, please, you've all got that, please fill that out for us. That informs our committee's selection of speakers for next year. And we will start in a few months to start planning next year's season. Also urge you to buy a lottery ticket. For just $100, you too could be eligible to win $5,000, and it makes things like this possible. So we ask you to do that. We also have a library survey, and I'm going to ask Ann in just a minute to speak a bit about that. Want to welcome folks who are watching live today on Facebook. If you missed today's, or any of your friends missed today's presentation, it will be on the library's YouTube channel, and you'll see it, they can see it on Facebook Live. So, Ann, can I?
Well, I've done this spiel now for about 4 Sundays at 2, and we're getting close to the end of collecting our data for our donors and our patrons. Anyone who holds a card can fill out an online survey, or we have paper copies, and we're happy to input the data for you. So I just want to give you one really exciting thing that just happened. We did this with our middle school students, both at the Lancaster Public Schools and at Chesapeake Academy, and we also provided surveys to our high school. 4 years ago, maybe we received 90. This year, we've received about 300, and we have some of the people on our board here who are inputting all of the data for our students. So really, really an opportunity to hear your voice as well as theirs. Thank you.
Thanks. And one last thing, I'd like to put in a plug for this Thursday. Shelley Robertson will be leading a discussion on Think Before You Click, Outsmarting Cryptocurrency and Other Modern Scams. So it's well worth your time to avoid having your computer crash and your bank account empty. So please, let me then turn to introducing Dr. James Melisi. Dr. Melisi is originally from New Jersey, where he graduated magna cum laude with a BS from Fairleigh Dickinson University. He then obtained his MD from State University of New York, Downstate College of Medicine with distinction medical research. His internship and residency were completed at George Washington University Medical Center. Realizing that he did not speak the language of medical management, Dr. Melisi also earned an MBA at Johns Hopkins University Carey Business School in Medical Services Management. He told me, though, that while understanding medical management was very important, he understood that, he really loves being a doctor, and he didn't want to become an administrator. And I know all of his patients are very grateful for that. Dr. Melisi has practiced neurosurgery in Reston, Virginia and Santa Fe, New Mexico, before joining Neurosurgical Associates in Richmond in 2015. Since early 2024, Dr. Melisi has offered Friday office hours to patients in Kilmarnock at 95 Harris Road, Building 6, Suite A. Which is, of course, adjacent to the Rappahannock General Hospital. Dr. Melisi and his wife Deborah have deep ties to the Northern Neck. They've owned a home in Heathsville for over 30 years and spent most weekends there. Dr. Melisi has requested that we hold our questions until the end of his talk, and he's also requested that nobody ask about your family member's MRI. There's something about HIPAA involved there. So with that, I turn it over to Dr. Melisi. Thank you, sir.
Change it to D1. Yeah, you can.
All right. We'll talk about that in a little while. So thank you for having me. It's an honor to be here to talk to you, especially after we had to postpone it for the weather. I'm so grateful to see so many people. A lot of my friends are here. Looks like some of my patients and others. I hope that I can match the quality of the speakers that you've had in the past, having looked at what they are. So I'd like to take you on a little journey. To me, I live and breathe neurosurgery on a regular basis, but to many of you, it's probably more like a black box, the inside of which you never really get to see. So I'm going to try and keep it a little light, sometimes serious. We'll see if we can inject a little bit of humor, and maybe you can learn a little bit of something about what I do. And in that note, I'd like to tell a real quick story. And looking out in the audience, I noticed that some of you might have heard this story before, so don't steal my thunder. So the story goes, and I'll apologize if there's any attorneys or lawyers here in the group. The story goes that there's a lawyer who lives a full life, and he dies, and he goes to heaven, and gets to the pearly gates, and St. Peter is visiting there, or meets him there, and he says to the lawyer as he's looking at the list, and he says, okay, you've lived a full life, you can come into heaven. The lawyer looks at St. Peter and he says, I'm not going into heaven if there's any neurosurgeons here in heaven. So St. Peter looks at him and he says, I assure you there are no neurosurgeons here. So the lawyer goes into heaven, he's walking around, and no sooner is he walking around than he sees a man there in a surgical gown and a cap and a mask, and he's clearly operating on somebody's brain, and he goes running back to St. Peter. He says, I thought you told me there were no neurosurgeons here in heaven. St. Peter said, there are none. And the lawyer says, well, who's that? And St. Peter looks, and he goes back and he says, that's just God. He thinks he's a neurosurgeon. All right, so hopefully by the end of this little talk, you'll be able to understand that we don't think we're God. We're not God. Neurosurgery can be extraordinarily rewarding, but it can also be extraordinarily humbling, and I hope that I can bring that point across to you. I have 2 plaques in my office. One of them is a quote by the sculptor and artist Michelangelo, and it says, "I am still learning." So I'm hoping that I can tell you a little bit about what I do and what I've learned over the course of 30 some odd years of doing this. The other plaque, hopefully by the end of the talk, I'll be able to make it obvious to you what that is. So the first thing that I want to talk to you about is just some concepts of neurosurgery. Neurosurgery is one of the most competitive and demanding specialties in medicine. It requires some of the longest training periods after medical school. The typical neurosurgeon goes to medical school for 4 years, and then through a rather brutal and selective, competitive process, they get selected into a residency training program after medical school that lasts for 7 years. Okay. And then some people choose to do a couple of years of a fellowship afterwards. So after the 7 years of training, you have learned hopefully the skills that you can use to be an independent neurosurgeon. As I said earlier, there's it's more like a black box, and I'm hoping that I can show you, kind of what's inside that black box, take you a little bit behind the curtain, so that you can see what it is, what it is that I do. The focus is on diagnosis and treatment of disorders of the brain, the spine, and peripheral nerves. So neurosurgeons take care of the brain, spinal cord, and nerves that kind of go out to the arms and legs. They play a critical role that can have profound impact on patients' lives, and we try not to lose sight of that. The interesting thing for me and for other neurosurgeons in the field is that it's constantly innovating. We have robotics now, novel treatments, neuronavigation, and even artificial intelligence for diagnostics. So I'll try and bring you through a little bit of that so that you can see not only what I did, but what the future holds. Talk to you a little bit about who goes into this and what are the training requirements so that you understand. Currently, there are about 117 neurosurgery residency training programs in the United States. It is a 7-year residency training program. That means that at any given time, there are 1,400 or so neurosurgical trainees throughout the United States in these training programs. And most programs graduate only 1 or 2 neurosurgeons a year. So you can see that it's a rather small group and rather selective and significantly quite competitive. In 2024, there were 380 applicants coming out of medical school for 240 spots. Board certification has a separate requirement. Board certification requires you take a written exam during the course of your 7-year residency. If we have time at the end and anyone wants to know a little bit more about that, we can talk about that. An oral exam is something that you have to take after you finish your residency training program and after you have completed about 2 years of clinical practice to show that what you're doing is appropriate, and generally the oral exam is administered by other neurosurgeons that are at a certain center for you to pass, and you have to pass that test in order to get board certified. So I talked about the skills necessary to become a neurosurgeon. Among the skills that one learns is that you learn how to take calculated risks with a sharp focus, but still with a significant amount of composure. So what I'd like to do is talk to you a little bit about the history of neurosurgery, and then a little bit about how I got there. what we do, and then at the end, a little bit about what I've learned. So, Harvey Cushing lived from 1869 to 1939, considered one of the pioneers of brain surgery and one of the fathers of American neurosurgery. He got his MD degree at Harvard, did his surgical residency under Halsted at Johns Hopkins University. A lot of these names are going to be somewhat unfamiliar to you, but Halsted was the first person among 3 others at Hopkins to actually start what was called the residency training program for people coming out of medical school. Actually, in those days, medications like cocaine and morphine were not really illegal, and they were experimenting with anesthetics, and because heretofore, before that, they didn't really have any anesthesia for surgical procedures, and Halsted was actually experimenting on himself with morphine and cocaine, and unfortunately, as you can imagine, became tolerant to it. Cushing was the first surgeon to exclusively practice neurosurgery. He was the fourth generation in a long line of physicians, and he learned when he was young manual dexterity through manual dexterity courses, something that would serve him very well later on in his career. He, as a result of World War I, neurosurgery was somewhat born, and under his influence, neurosurgery became an autonomous and individual discipline or practice. And it can be said that he was one of the leading teachers of neurosurgery in the early 20th century. Most neurosurgeons can trace their training back to one of 2 neurosurgeons. Cushing's last resident trained the chief of neurosurgery at SUNY Downstate College of Medicine, where you heard that I went in New York. And then that neurosurgeon was my first mentor while I was in medical school. So I can trace some of my heritage back to one of the original fathers of neurosurgery. He left Johns Hopkins and went to the Peter Bent Brigham and Harvard University, and then later on to Yale University, but a giant in the field of neurosurgery. The other giant is Walter Dandy, born in 1886, died in 1946, also considered one of the founding fathers of American neurosurgery, together with Cushing and Victor Horsley, who we'll hear about next. He trained under Cushing before Cushing left and went to Harvard, and he stayed at Johns Hopkins University for his entire career. Dandy made major contributions to the understanding of the flow of cerebrospinal fluid. Many of you are familiar with a spinal tap. So that flow of spinal fluid actually goes from the brain all the way down to the back and then back up. He was one of the first people to actually describe that circulation. He also was one of the first people to image the brain. Before that, we had absolutely no way of looking at the brain through images like X-rays, MRI, or anything like that. He came up with a way to image the brain by injecting air into the fluid-filled spaces via a spinal tap, and then doing X-rays as the air circulated in and around the area of the brain. And somewhere in the basement of some old hospitals, we might be able to find the chair that they put patients in, because they had to flip the patients around and let the air go into different areas of the brain, and then they would shoot X-rays, and they would be able to infer indirectly where a mass was, like a tumor. When I took my written boards, as I said earlier, you had to take a written board during your residency training, was the last year that anybody had to actually be able to read these pneumoencephalograms because we don't do them anymore, thankfully. But up until the 1970s, when CAT scans got invented, that was all we had. And he was the man who discovered or implemented a way that we could image them. He also was one of the first people to clip or ligate an aneurysm. I'll show you a picture later what an aneurysm really looks like and how we treat those. And he was one of the first persons in his career to actually treat via an operation an aneurysm. Sir Victor Alexander Hayden Horsley, knighted in 1902, born of privilege in London, was given his name by Queen Victoria, was the first surgeon to remove a spinal tumor via laminectomy, and went on to join the Royal Medical Corps and serve time like Cushing did during World War I. In the late 1800s, he was appointed professor at the picture there on the left at the National Hospital for the Paralyzed and the Epileptic. That hospital later changed its name to the National Hospital for Neurology and Neurosurgery. Not nearly as interesting as the first name. In front of that hospital, that building is still there. The newer building has been built around it, but it's in Bloomsbury, London. And it's still there, and in front of that hospital is a square or park. And in the park is a statue of Queen Charlotte. Queen Charlotte doesn't really register or mean a lot, but the fact is that the name of that square is called Queen Square. And the hospital has become affectionately known as Queen Square Hospital. It is the premier neurology, neurosurgery training center in the world, or at least among the premier hospitals. In 1990, while I was in my residency at George Washington, I had the opportunity to go there and train with the neurologists and neurosurgeons there. There's a ward in the hospital that has the name of several of the big names in neurology, neurosurgery. Victor Horsley has his name there. All right, so neurosurgery in some form has been practiced probably since the Stone Age. Certainly since at least 1600 BC, when these trepanned Incan skulls from Mesoamerica were discovered. If you go to the Smithsonian Institute in DC, to the Museum of History, Natural History, there's a room that has drawers with several of these skulls. The thing I want to point out to you is, again, remember, this was in the 1600s. It was the trepanned skulls were, or the trepanation was being done probably for medical and probably ritualistic reasons. But what's important is that if you notice, there's a big ring where the original hole was made. But in the center, there's thinner bone, and it looks like the bone is growing across. So what does that mean? That means that they survived, right? It means they survived, and there's evidence to suggest that about 70 to 90% of the people that underwent trepanation survived. I had the opportunity to go to Egypt a couple of years ago, and while we were there at one of the ancient sites, we came across these series of hieroglyphics. And it's a little small in the picture, but Cushing had his name attached to this. It's a Cushing retractor. And you can see that some of the medicinal and surgical instruments we're still using. The Edwin Smith papyrus was discovered in Egypt in the 1800s. It is one of the oldest medical texts that exists, and it specifically describes head trauma and spinal trauma. In the treatise, it goes on to discuss the diagnosis and prognosis and treatment plans for these types of injuries. Its importance is that it actually utilized the science that was known in the day, and not magic like a lot of the other treatment plans that were being used during that time. So the treatise ends with the physician describing 3 judgments: a condition that I will treat, a condition for which I will contend, in other words, they might get better, and a condition that I will not treat. So all the way back 1600 BC and probably earlier, because it probably represents a copy of something that had been written earlier. They were practicing some form of neurosurgical intervention. All right, so I heard somebody ask, what is it that we're looking at in that video? So when one wants to get inside the brain, you have to take a window of bone off in order to get in there. And what I was doing in that video was drilling starter holes. I told my father a long time ago, it's just Black & Decker sterilized. You have to drill starter holes, and then you connect the dots, just like you did in the 5th grade, with a very high-speed saw that circulates at about 75,000 RPM. And when you connect the dots, you're able to remove a piece of the bone, and then that gets you access into the head. And then, unlike what some people may be concerned about, we put everything back at the end. So I usually tell patients there's certain portions of the operation. One is getting in, one is doing what I need to do, and then the last part is putting everything back. So you see, we don't really put plates in people's heads, okay? But what we do use nowadays are these titanium plates that hold the bone together to the area of the skull, so that we keep it secure. The slide, the picture on the right is a representation from a museum that I went to about 2 years ago. It's a World War I museum. Remember I told you that neurosurgery was kind of born out of the circumstances around World War I and the injuries that occurred to people. And the trauma surgeons and the like were the ones who, like Cushing and others, were the ones who developed neurosurgery and became exclusively neurosurgeons. And you might recognize that some of these instruments, not only do we still use, but they were the same instruments that we saw in the hieroglyphics back in Egypt. All right, so hopefully you can all read this. One of the nice things about my career is that I'm forever getting gifts from patients. And this was a gift from a patient. What is a neurosurgeon? A creature that sleeps 2 hours a week, consumes entirely too much caffeine, and likes to overuse words such as juxtaposition. Right, the only difference is I don't really drink that much caffeine. And what is neurosurgery? Neurosurgery is as easy as riding a bike, except the bike is on fire, you're on fire, everything is on fire, and you're in hell. I put that there because I wanted to emphasize that there are certain characteristics that people go into throughout in their careers. And if you look at different careers, some of the people who go into these careers have very similar types of personalities and characteristics. And I would just leave it with you at this point with this picture, that if your house is on fire, you want the person who's going to run into the fire. So how did I get here? When I was 14, I had already decided that I wanted to be a doctor. I'm not sure that I would recommend that to many youngsters, but the fact is that in speaking to a lot of my partners that I work with, we all had decided in some way at a very young age that we wanted to go into this field. And at the age of 14, I also decided that I wanted to be a neurosurgeon. And the story goes that my 8th grade English teacher had assigned this this article out of the Reader's Digest. I read the article. About 6 or 8 months later, I graduated from the 8th grade, and we had to fill out a yearbook. And in my yearbook, a lot of my classmates were writing what they wanted to be in the future, and they wrote football player, baseball player, and I wrote neurosurgeon. I actually had the opportunity within the last week or two to communicate with that 8th grade teacher. He's still alive. He's living in Florida. He actually had brain surgery. And he had no idea that this had influenced me until I told him. And he told me that his supervisor was not happy with the fact that he was having the students read articles out of the Reader's Digest. The other book I read at the same time was a book by William Nolan, who became a very popular general surgeon in Minnesota. I know there's some people here that hail from there. But he was a resident in the 1960s and 70s at Bellevue Hospital in New York, which is a big city hospital. They see all kinds of problems, very similar to Kings County Hospital, which is where I went to medical school in Brooklyn, New York. So you see pretty much everything at these places. And he wrote a book about the making of a surgeon. And interestingly, it was in a period when no women went into surgery. So when you read the book, you realize as he's writing it that all of the co-residents that he's working with and training and going through the training program are all men. But nonetheless, I read this book, and that's when I came in. Between that and the Reader's Digest version, I came out with, I want to be a neurosurgeon, and that's what I'm going to do. And I stayed on that path, and I never strayed from it. I don't know if I was too young to do it. I don't know if I would recommend it, but as I said, it's not uncommon for those of us who go into these careers. And if you talk to many of the people that go into these kind of careers, a lot of them did have that vision early in life. And luckily, we got there because I had no backup plan. I thought I did. I even thought I did years later when I thought about getting an MBA, but that's when I realized how much I still love being a neurosurgeon. When I met my wife, her sister's husband was recently a graduate of the Naval Academy, and he was a helicopter pilot. And he would tell me stories about going through the Naval Academy and going through flight school. And I looked at him and I said, that's just neurosurgery residency, just the names are changed. All right, so I grew up in the 60s and the 70s during the period of the space race and the Apollo trips to the moon. So these were my heroes. And I was very lucky to have the opportunity to meet several of the men who walked on the moon throughout my career, including Gene Cernan on the left, who was the last person to walk on the moon, and Jim Lovell, who you might remember the name from the Apollo 13 movie. Lovell I got to hear talk several times, and that's when I realized that this was another group of people with certain characteristics, and I'll apologize right away, I'm no astronaut. But when you hear their stories, and you hear the story about their lives, they're extraordinarily similar to the firemen, the fighter pilots, the surgeons and others. You might recall the story where they were about 2/3 of the way to the moon, and they had an explosion on the spaceship and an oxygen tank exploded. And a significant portion of the spaceship actually went off out into outer space. And he looked outside the window and he sees this venting of some sort of object, going out into outer space. And he says, with probably the understatement of the century, Houston, we've had a problem. And the reason I say that is because during the course of neurosurgical procedures, we have to be able to react with precision and under extraordinary conditions. And in particular, I can think of one operation where we're actually clipping an aneurysm. You heard earlier I talked to you about how Dandy was one of the first people to clip an aneurysm. And I'll get to a picture, but an aneurysm is really a vascular malformation on a blood vessel where it's very leaky and it potentially could rupture. And if it ruptures, because it's an artery, it ruptures under pressure. And if it ruptures during the course of dissecting it out so that you can put a clip on it and ligate it, then you could potentially have a catastrophic blood loss. And it's one of the operations, one of the few operations that neurosurgeons have been known to kind of cut their teeth on, so to speak. In other words, that's the procedure where you can have significant catastrophic problems, and you have to be able to react with precision and under extreme conditions with significant composure. So, the alternative to this talk was, the title was going to be Everything I Need to Know About Neurosurgery I Learned Running Cross Country. Remember I told you that I decided at the tender age of 14 that I wanted to be a neurosurgeon. So I left elementary school and I went to high school. And on my first day of high school, the man in the middle was my track coach and cross country coach. And we recently had a reunion with some of my track buddies that I hadn't seen for many years. Well, my track coach walked into our freshman high school room on the first day of school, and he said, I need people to run cross country. And I thought, why do I want to run to California? Obviously, I didn't know what it was. And Forrest Gump hadn't been produced yet. However, there were several things that I learned from running cross country. I learned dedication, self-motivation, perseverance, resilience, and stamina. Stamina because it's not unusual for us to have to operate on certain conditions or problems in the brain that could last 8, 10, 12, 14 hours without a break. Obviously, I was able to carry that running career for a fair amount of time, although why I was still running, well, I had to have little braces around my knees. But neurosurgeons are crazy people, and we're always looking for the next challenge. That brotherhood that developed among my co-runners was the same brotherhood that I developed with my co-residents. Again, similar to, if some of the people in the audience are in the military, not unlike that kind of group or band of brothers. Because you start out in the early parts of the residency training program, and they bring you through a significant number of years where you hone your skills, and you get to be extraordinarily close to the people that you're living more with than your own families. Because the call schedules and the requirements of living in the hospital and taking care of patients and being there on a regular basis, that becomes not your family, but a second family. Unfortunately, the guy in the middle, who was one of my best friends, is no longer with us. But the man on the right is here, and I'm here. We had a reunion. We had a reunion a couple of years ago in DC. So those are the people that I trained with. And you don't lose that brotherhood throughout the course of your life. So let me tell you a little bit about what we do. So I said earlier, we take care of things in the brain, things in the spinal cord, and peripheral nerves. Gliomas are the generic term for a malignant brain tumor. And I will tell you another quick story. I told you earlier about, in order to get board certified, you have to take a written exam and then an oral exam. The oral exam I had to take, I had to fly to Houston, go to a hospital there, and be examined by probably a dozen different neurosurgeons over the course of 8 hours, where they just pepper you with different cases of neurosurgical problems, basically until you can't answer anymore. And then you move on to the next question. And the night before, now remember, I said when I was 14 years old, I wanted to be a neurosurgeon. Now I'm 35 years old, and I'm taking my board exam for the first time. And I'm thinking in my head, if I pass this exam, I will be a neurosurgeon. So I and the other candidates that were in the room obviously were very nervous. And the night before, they had a crash course. Now, it turns out, of course, if you look back, did I need to take that crash course the night before? It just gave us something to do so that we weren't someplace else being worried. But the examiner, or the teacher of that crash course the night before, looked around the room just like I'm looking around now, and he looked at the people and he said, I can see you're all very nervous about the test you're going to take tomorrow, and that it obviously has ramifications about whether or not you become board certified in neurosurgery. He says, I just want you to remember one thing when you're taking that test. You are not the one with the brain tumor. Changed my life. First of all, I wasn't nervous anymore. And secondly, it gave us a certain amount of empathy and realizing that for the most part, things that come up in life are fixable. Albeit there are a few that maybe you can't. But until somebody tells you you have a malignant cancerous brain tumor, most of the problems can be dealt with. So I say that because the white thing in the lobe of the brain there, that's what a malignant brain tumor looks like on an MRI, okay? And we also know from scientific experiments that there are cells in and around the area of the brain on the outside that are also malignant, you just can't see them. So that's why you can't go in there and just take a whole swath of brain tissue out, because you hurt people. So we know that there are going to be other cells in and around that area. So you have to get, in addition to the surgery, other forms of treatment like chemotherapy and radiation. But even if you do that, the median survival is about 1 year. That means the midpoint is about 1 year for survival if you have a malignant brain tumor. The most common type of tumor, however, that we take out, with a little better news, are brain metastases, or tumors that have spread from other places. And they come mostly from the lung, the breast, and the colon. But because the oncologists these days are able to treat the systemic disease, the disease everything below the neck, if we can control the brain disease, patients go on to live much longer than they did even 5, 6, 7 years ago. So we're much more successful with brain metastases. One of the innovations that came about in recent years is something that's completely revolutionized neurosurgery and continues to be innovated in the future with maybe virtual reality and AI. But we call it GPS in the operating room. It's basically neuronavigation, And just like with GPS, we have a camera in the room that acts as a satellite. We have a receiver in the room that we have as a probe. And then we've got a map, which is really the imaging study, so the MRI or the CAT scan. And on the right, you see the analogous pieces of instrumentation, such that I can touch any area of the brain and know exactly where I am because the images come up when I'm touching any area of the brain or the skull. What that has done for us is it has significantly improved outcomes, shortened operating times, made for smaller incisions. Overall, when I look at it, I don't know how we were able to operate even 20 or 30 years ago where we had to not guess, but using the imaging studies, we had to plan incisions which had to be bigger and use other instruments to find what we were looking for. Now we can just take a probe and just touch areas of the brain and the pictures come right up and tell us exactly where we are. So here's an example. You see the camera, the orange thing on the top, you see the screen, and then the probe, is in, could be in my hand, and you can just touch anything, even looking under a microscope and the pictures come up. I talked to you a little bit earlier about aneurysms. So this is an aneurysm. Okay? You see normal, this is a 3D image of the vasculature of the brain. That's a blind sac, it doesn't go anywhere. The importance of that anatomy is that the aneurysm is a weak part of the blood vessel. I think all of you, myself included, know what a bubble on a bicycle tire tube is, right? So that's about what it's like, right? It's a weak point and it runs the risk of rupturing, and when it ruptures under pressure because you have a head of pressure behind it, and that pressure is what injures the brain, and that's why 30% of the people never make it to the hospital and 60% of the people are never the same. So the goal is to try, if they do get to the hospital, is to try and ligate that aneurysm at its base, just like putting a clip on the base of a balloon, so that the top of it doesn't re-rupture and bleed again. So that's the goal. It's one of the most delicate types of operations because, as I said, during the dissection, the top of it could rupture, and if it ruptures, it gets flooded with blood, and you have to be able to maintain composure and have precise ways of continuing the dissection while maintaining your composure to put a clip on it. In the middle slide is are examples of what the clips are, and you can see the size compared to the top of a pen. And then on the right, you see normal blood vessel, the lobes of the brain. And when you operate, you have to operate usually through the temple. You go underneath the brain, you split the fissure that separates the lobes of the brain, and then using a microscope, you dive down underneath the brain, you find the blood vessels, you trace the blood vessels, and then eventually you get to the aneurysm, and you put a clip on it. The art of doing that kind of surgery is that you have to be prepared. And my wife, standing here as an example, in the middle of the savannah with a storm approaching, and then the truck ended up in the ditch, and we're wondering where the cheetahs and the lions are going to be, just like when we're dissecting out the vessels, and we're wondering, is it going to rupture, is it not? You have to be prepared. Luckily, the guide had a big chain, and there was another truck, and we were able to attach it to the other truck, and he pulled us out. So the whole key to doing that kind of surgery is to be prepared. This is the optic nerve going to the eye, lobe of the brain, and a benign brain tumor. As we're dissecting it out, you see a little bit more of the optic nerve, and then at the end, you're able to see the optic nerve, the carotid artery that the tumor was investing, and then another cranial nerve here that goes to the eye that allows the eye to move back and forth. So those are that's where I live. Spinal navigation, I talked to you just a few minutes ago about navigating through the brain. We can also use navigation in the spine, and it's not unlike, when I'm doing it, I feel like this is not unlike docking a boat. or in this case, SpaceX docking a capsule in the space station. Because what we have is that round device is a CAT scan in the operating room. And I'm trying to navigate a screw into a vertebral body that I can't see. Because all I see when I have the incision open is the back side of the spine. Somewhere on the other side of that is the vertebral body that I've got to put a screw into. So you can see in the picture on the top here, that pink screw is a representation of what I have in my hand, and I'm watching the screen. So I'm not even actually watching where the incision is. I'm watching the screen as I'm navigating the screw down into the vertebrae. And again, it has completely revolutionized the way we do that surgery. Before that, we had to get multiple x-rays, and as we were putting the screw down, you get another x-ray. You subject the patient to more and more radiation. You're not always exactly clear where it is because you're doing it under 2D. This gives us a 3D representation of exactly where our hardware is going. It's cut the timing of the time of the operation, which means less anesthesia and better outcomes. I thought you might want to see what a spinal cord looks like. So on the top left is what the spinal cord looks like. That's a suction device that's up and that's on top of it. This is a tumor that was pressing on the spinal cord, and when the tumor came out, that's what it looks like. And then when you close it up, and we have an example of what spinal surgery looks like. Just again, some of the things that neurosurgeons and neurosurgery in general is capable of doing, and it never ceases, to not necessarily amaze me, but keep me interested in being able to do something like that. So, reflections. What have I learned? Neurosurgery can be extraordinarily rewarding, particularly when you realize that you're making a difference significantly in the lives of others and other people's families, particularly when they are at their most vulnerable. I've also learned that you need to be able to have precise technical skills with somewhat confidence, but not arrogance. And perhaps even more importantly, you have to have what I call emotional resilience. One of my other professors that I had in residency training, he used to say, when we were in the middle of an operation, he didn't like noise in the operating room. And if there was a little extra noise or somebody was playing a radio, he would say, can we dispense with the levity? The only two people I want to hear is Dr. Melisi and God. But he also taught me that it's not my fault if somebody has a bad disease. It's not my fault if somebody has a bad outcome because of their bad disease. It's my job to make sure that we treat them as best as we can, and then be able to move on to the next person, because that person deserves the same quality of care as the previous one. So one of the things that I learned from somebody here in the Northern Neck, actually, I had the privilege of taking care of her elderly mother, and I always had a problem with patients who came to me afterwards to say thank you. I was embarrassed, I didn't know exactly how to respond, but I learned from her and others that I have to let those family members or those patients say thank you. Before that, I would just say, well, it's my job, it's what I do, and like the firefighter, this is what I do, I'm not a hero, this is something I'm trained for. But I learned that it was very important to let them show me and others that they were grateful. And that's one of the best parts about my job. I don't do it for my ego anymore. The man on the left was a fighter pilot in the Vietnam War. He was one of the first people to be shot down and was imprisoned in the Hanoi Hilton for 7 years. Right? He's actually a very famous guy, still living in Richmond. Came from New Jersey like I did. And he told me that it's a good day if you wake up and the doorknob is on your side of the door. I told you earlier about Walter Dandy, how he discovered the pathways for spinal fluid, and he had a very common problem that neurosurgeons treat. The lay public knows it as water on the brain or hydrocephalus. He had a blockage of the spinal fluid, and his memory was becoming a problem. He was having difficulty walking. And this was a guy, like I said, who was incredibly intense, was a fighter pilot, and we ended up putting a shunt in him, and he's become a really good friend of mine now, and was forever grateful, and basically brought him back to what his baseline was before I met him. The other lady in the middle, she comes back every year just to come back. I don't need to see her, she's doing fine. We treated her for a brain problem, but she just loves to come back, and she always comes back dressed up, and she's always so grateful. The other man is, I told you earlier that we have to be able to perform under extreme conditions, to persevere through the fatigue, and continue going because, quite frankly, failure is not an option in our career. This man had a tumor that was right smack in the middle of his head. And it was about the size of maybe a big egg. And it was early in my career. In fact, it was about 25 years ago or more that I operated on it. And it took 16 to 18 hours to take out that tumor. Now, I was very young, and I was capable of sitting there under the microscope for that long. I think maybe I took only one break at the time. But we actually had to leave a very tiny amount of the tumor because it was attached to a part of the brainstem that I just couldn't. Every time I touched it, his heart rate went down. And so we left a little bit of the tumor there, and we sent him to radiation therapy, and it melted away. The rest of it just melted away. And he is shown in this picture now about 28 years or 30 years later. You heard that I actually started out in Richmond 28 or 30 years ago, and that's when I operated on him. Then I went up to Northern Virginia, and I kind of lost track of him, and then I came back to Richmond, and he found me. And now he comes back every year for the last 10 or 12 years just so that I can check on him. So, don't sweat the small stuff. And every once in a while, I am convinced that in the middle of an operation, I know I'm going over a little bit, but I'll be done soon. Every once in a while, I am convinced in the middle of an operation, particularly when I'm struggling a little bit and it's a little difficult, and I'm wondering, why am I there? It's not uncommon for me to get a little bit of divine intervention. I promised you that I would tell you what the other plaque is. That's on my desk. And it's a quote that actually started out as a pin that I was able to put on the lapel of my white coat way back when I was an intern. And it epitomizes how I approach most of the things that I see today. And I hope that after this little discussion, you'll be able to appreciate and understand the metaphor behind it? I'll take questions.
We have a microphone on that side, we have a microphone on this side. Raise your hand and we'll get it to you.
So obviously, over your 30 years, technology has rapidly changed. How do you keep up with that?
That's a great question, and it's not easy. Now, there's two ways, I would say. One is that in order to remain board certified, you don't just take a written test and take a oral test. We have to keep up with the literature and state of the art and be able to show a significant amount of continuing medical education on a yearly basis. And we have to produce that and show it to the American Board of Neurosurgery. So we're constantly taking courses, constantly learning new innovations, constantly learning new surgical procedures. So yeah, the short answer is we do have to stay up with the technology and the literature, and we have to be able to show that we've done that. So we do. I think she's got a microphone there.
No, I don't think about it.
You hear me? If I suspect in neurosurgery, long answers are probably way more important for a patient to hear than the short answer. But I know that I can find you in Suite A for the long answer. So for now, for the short answer, if a patient was told that if a patient had severe, debilitating, intermittent cranial nerve pain, but was not fully aware of what cranial nerve it is, what specialist would be best to pursue?
All right, that's kind of hinging on the, don't ask me about your family. So you asked for the short answer. The short answer is, remember I showed you that hospital that's in London, where it's the premier hospital and remember I told you that it's a 7-year residency training program? So the short answer to that question is, it's a long training program. And that's what you have, those are the things you have to learn. And with the advent of imaging studies, MRI, CAT scans, and others, it has kind of eliminated the art of neurology, where they used to have to decide where the lesion was just based on the physical exam and the history. And that's what neurologists and neurosurgeons used to be really good at. And imaging studies now have been able to show, well, look, there's the stroke right there. But you can talk to me later about who you need to talk to. You had a question.
We've got one right here, and then we'll come up there.
Okay.
There you go.
I wondered if you could touch on synesthesia.
On what?
Synesthesia? Synesthesia?
Synesthesia, I'm not sure
I
what.
think I'm
synesthesia-
going to say that one has got me somewhat stumped.
See colors, hear colors. You can hear colors, or
Yeah, exactly.
You hear colors.
or any other
See music.
combination of senses.
So senses that are kind of mixed together. So, again, trying to be brief in my answers. One of the things that still fascinates me every time I turn a bone flap like that and look inside and look at the brain and touch the brain is that we are still utterly amazed at the connections and the ability of the human brain. And a lot of times we discovered certain disease states were discovered or based on how things went wrong. And I suspect that remember, this is all electrical, and you've got chemical synapses or connections that actually then serve to become electrical. And if you've got electrical connections that are not exactly talking to each other, I can imagine that. But I'm happy to talk to you about that later if you want. I think he had a question.
do this one, and this one will be our last one, and then we'll break for coffee and cookies, and you can, Dr. Melisi will still be here and available to talk to you. So we're gonna let this gentleman, and then you're next.
Do you at some point, Ms. Hunt,
Yes.
see yourself teaching what you do and how you can add to the knowledge of others in the future? And, you know, at some point, you may phase out of actually doing to help others come along and do what you do.
Quicker than you think. I'm at a transition point in my career right now, and I am looking at all of those things about how I can teach, how I can give back. I didn't talk to you really about who some of the other mentors were who helped me to get into medical school. I've been lucky enough to help some others to do that as well. So yes, it's all of that is coming up pretty quickly. I just haven't decided where I want to write the book or what I want to do.
Got one last question here, and then we'll break for cookies and coffee.
Yes, thank you, Dr. Melisi. Do you have an age or do you have an age or a diagnosis preference that really resonates with your work?
So I'm a general neurosurgeon that treats adults, so I don't do pediatrics. Pediatrics is a completely separate board certification. It didn't used to be, but it became, we were able to do so many different things later on that it became obvious that you had to train specially if you wanted to do, for example, pediatrics. I had a special interest in brain tumors, that's why I put that slide up there early on, and I still do have a special interest in it. We know a lot more about the molecular biology of brain tumors. I can't say that we are better at the outcomes to date, but yeah, if I had to say that I have a special interest in something, malignant brain tumors was something that I was particularly interested in.
Can you take one more question?
Yeah.
You look like a young man. You're very well dressed, you probably got best dressed resident back in the day, right? But you don't, particularly in the northern neck, you don't see a lot of bow ties. Bow ties.
He's a plant. Obviously, he doesn't. You're not in the same circles that I am in the northern neck. I see a lot of bow ties.
Okay, I think in to honor everybody's time, we're gonna have to call it an end, but he is still here and can answer questions.
It's a neurosurgeon thing. And not only is it a neurosurgeon thing, but you have to be able to tie it. If you can't tie it, you can't wear it.
On that note,